All right, welcome back, everybody. We're very pleased to have the last two speakers of this session, and I think it's great that we've had such interactive audience members. So we really look forward to getting questions on the Q&A. And again, if we don't get a chance to answer all of them, I think most of the speakers will try to get back to you individually. For the next talk, we're going to get a little bit of geographic diversity and have a speaker from New Orleans. Meredith Clement is an associate professor of clinical medicine at LSU. She's going to share her slides with us in a moment. She trained in ID at Duke, and she's really been focused on sexually transmitted diseases, which has a long history for excellent research at LSU. And she's focused on prevention of STDs and HIV. So we're excited to have her talk about STI prevention and to tell us what we need to know about DoxyPEP. So Meredith, thanks for joining us.
Yeah, let me just click on my slides here and get them where I need to be. Okay, thank you so much, and thanks. I'm so excited to be here and talk to you. The title of my talk is Updates in STI Prevention and Treatment, DoxyPEP, and more. And with that, I will get started. All right, here are my disclosures and the learning objectives. So my hope is that today, upon completion of this activity, that you will be able to describe recent trends in syphilis epidemiology. And I'm going to talk a bit about congenital syphilis because if you have been watching the news lately or paying attention to what the CDC is putting out in terms of syphilis epidemiology, you're quite aware that the rates of congenital syphilis have skyrocketed in recent years. Then I'm going to talk about management of syphilis in the setting of recent drug shortages and hopefully engender some discussion about that, but provide some guidance and on what drugs we're using given the recent shortages of penicillin. And then finally, to talk about some of the risks and benefits of antibiotic prophylaxis for STIs, particularly bacterial STIs. So 2021 data has been released by the CDC, kind of the state of the STDs. You may have seen slides like this in the past. Each year they show us what's going on with chlamydia, gonorrhea, and syphilis. And while chlamydia has kind of been stable to slightly decreasing since 2017, the rates of gonorrhea have increased by 28% since 2017, and remarkably, cases of syphilis have increased by 74% since 2017. So 2021 is the most recent year for which we have reliable data. And in 2021, we saw more than 176 cases of syphilis. And that includes more than 2,800 cases of syphilis among newborns. And as many of you know, congenital syphilis can be quite devastating. It can lead to stillbirths, fetal demise. And sadly, I think what's particularly devastating is it's very preventable. And so this is another slide to kind of just give you a picture of the recent trends in syphilis epidemiology. This is looking specifically at primary and secondary syphilis. So those are the infectious stages of syphilis that are most trackable. And while MSM, men who have sex with men, can continue to comprise the majority of cases, what we're seeing is kind of this really dramatic uptake among cisgender women or heterosexual cisgender women. Unfortunately, the CDC does not give us great data of non-binary and transgender individuals, but we do know that among cisgender women, we continue to see significant increases. And so this data from 2020 to 2021, this uptick represents a 55% increase among heterosexual cisgender women. And so with congenital, in parallel to that increase or that uptick among cisgender women, what we're seeing is a dramatic increase of congenital syphilis. And so this shows you again the 2021 rate, so more than 2,500 cases of congenital syphilis in 2021. What I've seen preliminarily for 2022 is 3,500 cases, so continues to increase, not getting significantly better. the data I saw recently, a kind of associated statistic with that, is that over the past decade, what we've seen in terms of the rise of congenital syphilis is a 900% increase in the rates of congenital syphilis. So I think we really do have our work to cut out for us in terms of, changing the trajectory here. So here is my first audience response question. So you are seeing a 36-year-old woman. She has HIV infection. She's not on ART. Her CD4 count is low at 152 with a percent of 10. Her viral load's not suppressed, 53,000. And she has been off ART for the past 2 years. She comes to you complaining of vulvar warts. So you do a physical exam and you are concerned about condyloma. You don't quite remember, is this condyloma lata versus acuminatum? It's been a while since you've had to think about that, but you do remember that one of these is associated with syphilis. So you order an RPR and it returns at 1 to 128. However, you hear that there is a penicillin shortage. What do you do? And so the question is, how would you treat this patient? 14 days of doxycycline tablets, 7.2 million units of benzathine penicillin G given IM, IV penicillin for 14 days, or something else. So I'll give you just a couple of seconds to answer that question. All right, let's move forward. And yeah, so 14 days of doxycycline tablets. Let me close that. So that is the correct answer. So this is secondary syphilis. In the setting of the bicillin shortage, we are generally giving doxycycline for secondary syphilis, a 14-day course. If the patient had late tertiary syphilis or late latent syphilis, we would give 7.2 million units of bicillin. For neurosyphilis, we give IV penicillin for 10 to 14 days. But the right answer here for secondary syphilis is 14 days of doxycycline in the setting of the bicillin shortage. So let's talk about condyloma lata for just a second. We don't see this very frequently, but again, it is a manifestation of secondary syphilis. So on physical exam, it's very hard to distinguish condyloma lata from condyloma acuminatum. I will say that the condyloma lata are typically flatter and more moist, but again, almost impossible to distinguish without additional information. And luckily, here you had an RPR, your clinical acumen was high, and you knew to order that. If by chance this patient had proceeded with biopsy, what we might have seen on histology is epidermal hyperplasia with superficial neutrophils and this really dense or intense dermal mononuclear infiltrate. And we can kind of distinguish that from HPV-related changes on biopsy. What we tend to see is these coilocytic changes. This is just squamous epithelial cells with perinuclear cavitation, and those are what kind of is more frequently seen in condyloma acuminatum. Okay, so now to talk about the shortage of benzathine penicillin. So we know that benzathine penicillin is really the treatment of choice for syphilis. It is the only recommended treatment for pregnant persons who are infected or exposed to syphilis. Unfortunately, Pfizer is the only manufacturer of BPG in the United States, and Pfizer had a manufacturing delay from 2016 to 2017. So this is not our first rodeo. I show that just to say that, we've dealt with this before. It's unfortunate that we're dealing with it again, and we shouldn't have to, but it is the situation, the kind of reality we're facing. And so I think it's really important to know what are our alternative treatments in the setting of a benzathine penicillin shortage. So the National Coalition of STD Directors, NCSD, has tried to advocate for us as treaters or caregivers for STI treatment. And so they have urged the White House Drug Shortage Task Force to prioritize action to end the ongoing shortage of bicillin LA or benzathine penicillin G. As of this moment, we are the kind of expectation is that shortage will not resolve until the second quarter of 2024. So for now, we do need workarounds. the CDC, if you go to their website, they do offer guidance about what we should be doing in the setting of the BPG shortage. And so, first of all, monitor doses very closely and request additional doses when needed. I'm going to show you some data in a second about how those additional doses aren't always provided when needed, but we should be at least monitoring them carefully. Secondly, preserve BPG for pregnant persons with syphilis diagnosis or who have been exposed to syphilis. So in our case, in our clinics in New Orleans, we, for a while under the BPG shortage, this became necessary that we would reserve BPG for pregnant persons only. Currently, we have enough to use for all adults, but it's kind of a changing, constantly evolving situation. And then just a reminder, or kind of re-emphasize the need to stage appropriately to avoid unnecessary use. So we always want to do a very thorough physical exam to maybe look for chancres that have gone unnoticed by the patient, in which case we could treat for primary syphilis and avoid additional unnecessary doses of benzathine penicillin G. Okay, so here is a survey. I mentioned NCSD, again, as an entity, the National Coalition of STD Directors. So they have sent out surveys in August and then again in November to survey clinics nationwide that provide STD care, to ask them how the benzathine penicillin shortage has impacted their clinics. And kind of the conclusion is that the bicillin LA shortage is having a widespread and direct impact on sexual health clinics getting the drug they need for patient care. And so just to give you a little bit of the data, I looked at the first survey a while ago, and it was already kind of remarkable how many clinics were having trouble with this. But the numbers have only exacerbated between August and November. So this continues to be a persistent problem. But right now, 46% of clinics are reporting that they've attempted to order bicillin LA, but the drug was not available. 55% of clinics have had orders completely unfilled. And then 40% of clinics have had their bicillin LA orders delayed in the past 3 months. And then I just want to highlight a really statistic from this survey that I found pretty remarkable, was that only 56% of clinics could say that they were able to get pregnant patients treatment within 1 week. So that means 44% of clinics are not able to get pregnant women and other persons treatment for syphilis within a week. And we know that there's an urgency there when it comes to pregnant persons and treatment of syphilis. Okay, so what are our alternatives here? And I just show this as systematic review. This was something that I published with a couple of colleagues now almost a decade ago. And one of the reasons I wanted to highlight it is because really very little has changed in the past decade regarding alternatives for syphilis treatment other than benzathine penicillin G. And then I also just wanted to talk about some of the gradings we gave the alternative treatments, because we graded using the American Heart Association classification to rate the quality of evidence. And again, not much has changed, although I will give some updates regarding some recent studies. So here is a table that we published, and I really just want to highlight here the therapies that received a grade of evidence A were sort of few and far between. So BPG for the treatment of early syphilis, meaning primary and secondary syphilis, and then also BPG for early latent syphilis. And then also azithromycin did receive a grade A treatment, but I think most of us know that we really don't use it. It's not recommended to be used in the United States for treatment of syphilis because macrolide resistance approaches 50% here. I will highlight that doxycycline received a grade B. We really tend to use doxycycline based on our many decades of experience with it and kind of monitoring clinical outcomes. But really the data is mostly retrospective cohort studies that support its use. And so I will show you kind of in the recent years, this is more publications that have been published 2016 to 2022. And the kind of punchline here is that this is all reassuring data. All these retrospective studies really kind of offer us reassurance that doxycycline is a reliable alternative to benzathine penicillin G. Let me go forward for a second. And then just to kind of show you some newer studies, a couple of these are more randomized trials, but small, looking at alternative agents. But I just wanted to highlight them because they've been published in recent years. So the first was a brief report published in CID, or Clinical Infectious Diseases, looking at cefixime for the treatment of early syphilis. And so this was 400 milligrams twice a day cefixime versus BPG for 10 days. I'm sorry, the cefixime was 10 days versus a single dose of BPG. They called this a randomized open label non-comparative pilot study. It was only 58 participants, and actually in the per protocol analysis, it was only 30 participants, so that's 15 in each arm. In the per protocol analysis, the response rate was pretty good, 93% with BPG relative to 87% with cefixime. In the attention to treat analysis, they had a fair number of loss to follow up. So the results were not quite as good, 81% BPG versus 57% with cefixime. And then kind of also another relatively recent study, 2015, high-dose oral amoxicillin plus probenecid, highly effective for syphilis in patients with HIV. I mostly highlight this. This is a retrospective study without a control group, but really just to highlight the overall efficacy of this arm was 95.5%. And this is in all patients who had HIV. Again, they got a higher dose of amoxicillin, 3 grams, and then probenecid as well. And so that led to this other study that was very recently published in September, looking at high-dose amoxicillin, again, 3 grams with probenecid versus low-dose amoxicillin monotherapy for treating syphilis. Again, all patients in this study, or all participants, had HIV infection. It was 112 participants who were randomized, so 56% in each arm. Kind of typical to these studies, they looked to assess the primary outcome. They looked at serological cure, so a 4-fold decline in titer at 12 months, and the response was 90.6% in the low-dose amoxicillin group versus 94.4% in the combination regimen. So again, very relatively high. I do want to highlight that this, both of these studies, the one I just presented and this one, both were studies that took place in Japan, where they do often use this regimen because they really have poor access to benzathine penicillin G. And this regimen is the amoxicillin plus probenecid regimen is in the UK guidelines as an alternative therapy for the treatment of syphilis. Notably, in this study, the low-dose regimen did not show non-inferiority to the combination regimen, but the authors sort of argued that both of these efficacy rates are quite high, so we should consider it as a potential treatment for syphilis. All right, now moving into STI prevention, hot topic here, doxycycline post-exposure prophylaxis. So kind of going back to where it all started, this is the IPERGAY-OLE open label extension study. The results of this study were published by Dr. Molina in Lancet ID in 2018. So the folks who qualified for this study were anybody who had been entered in the IPERGAY PrEP study. So that was considered HIV negative, high risk MSM, or men who have sex with men who didn't have a contraindication to doxy. They were randomized 1-to-1 to get on-demand PEP with doxycycline within 72 hours of sexual activity versus no PEP. There were 232 participants, and they were followed for about 9 months. And here are the results. So there was a significant decline in the time to first STI or in the hazard ratio, looking at time to first STI when you consider all STIs. So this was gonorrhea, syphilis, and chlamydia. When looking at gonorrhea specifically, so France, where this study took place, has a high rate of tetracycline resistance with gonorrhea. So there was actually not a notable difference in the PEP versus no PEP arms. But for syphilis and particularly for chlamydia, there was a dramatic drop in rates of both of these STIs. Okay, so now moving into the DoxyPEP study. So this study was initially presented at AIDS 2022 by Annie Lukemeyer. It was subsequently published in the New England Journal of Medicine recently. And this study took place in Seattle and San Francisco. The investigators plan to enroll approximately 780 participants, so half living with HIV, half HIV negative on PrEP. It was all men who have sex with men and transgender women. It was 2-to-1 randomization, DoxyPEP or no PEP. I will say the study was stopped early, so they didn't quite reach these numbers. The study was stopped early by the DSMB because of efficacy signal for DoxyPEP. Kind of the inclusion criteria listed here. They did quarterly 3-site gonorrhea and chlamydia testing. So just to kind of go over the outcome for this study, it wasn't your typical STI incidence rate, so number of infections over 100 person years. What they did is looked at the proportion that had an STI per quarter, so at each kind of 3-month testing interval. And they also did resistance testing. So they tested samples for gonorrhea, Staph aureus, and commensal Neisseria species. And that was done for both arms. So here is the results of the primary endpoint. So looking again at these quarterly visits with at least one STI. First on the left, the PrEP arm taking PrEP. So you have a really pretty dramatic difference in the percent diagnosed with an STI, 10.7% in the DoxyPEP arm versus 32% in the standard of care arm. That's a reduction of about 2/3. And the absolute difference is 21.2 percentage points. And strikingly similar results in the HIV arm, those folks living with HIV, 30.5% in the standard of care versus 11.8 in the DoxyPEP arm. So that's 18.7% percentage points difference. Here's the Kaplan-Meier, pretty easy to visualize the difference between the standard of care groups and the DoxyPEP groups here. And then now to talk about the resistance. So I think really kind of at the end of the day, the conclusion probably is we're quite limited here to look at resistance because of the very low numbers of samples available. But just to say that these are incident, not baseline infections, but within the doxycycline, 5 cases of resistant or tetracycline resistant gonorrhea were noted versus 2 cases among the control group. And then for doxycycline resistant Staph aureus, we saw 5 cases of incident infection in the DoxyPEP group versus 2 cases in the standard of care group. And so this leads us to a question about DoxyPEP. This is a 24-year-old transgender woman. She's presenting to your sexual health center for STI screening. She reports a recent diagnoses of both chlamydia and gonorrhea. So you tell her about the use of doxycycline for STI prevention, and she's very interested. You counsel her on how to take it and then advise her on side effects. Which of the following is correct if she starts doxycycline? And here are your answers. She will be at increased risk of Clostridium difficile or C. diff infection. She should take the pill with food, particularly dairy. She may experience GI symptoms as a side effect. Or D, the medication can cause esophageal injury due to its high pH. And I'll give you just 1 second to answer those. All right, let's see the results here. And 84%, great. So she may experience GI symptoms as a side effect. She won't be at increased risk of C. diff. I'll show you some data about that in a second. she can or maybe should take the pill with food to minimize the GI side effects or the GI symptoms, but not take it with dairy because that will interfere with absorption. And then finally, the medication can cause esophageal injury. We know that. We always advise patients to take it with a full glass of water and to remain upright for 30 minutes after they take it. But that's due to its low pH, not its high pH. So I could not fool you guys here. So let's talk about some of the side effects from the DoxyPEP study for just a moment. So nausea was a bit more common, 6.7 versus 3.2%, but vomiting was not. Diarrhea was also a bit more common, 12.1% versus 9.2%. Abdominal pain was essentially the same in both groups. And then notably, only 2% of study participants in the DoxyPEP arm discontinued because of unacceptable adverse events or just a general preference to stop taking. So overall, I think that's a pretty low result or percent of dropout, kind of reassuring us that in general, DoxyPEP was pretty tolerable. And actually, I'm not showing it here, but the acceptability data was quite high too. Okay, so here's the C. diff data as promised. This is a study that was published earlier this year in OFID. Kind of clever, the authors identified 159,000 cases of C. diff infection and almost 800,000 controls. And then they looked at the antibiotics that folks had received. And then they ordered the antibiotics. They looked at kind of the odds ratios for likelihood of C. diff development. And they ordered the antibiotics in terms of their relative level of associated risk for C. diff infection. So I apologize that this is a little blurry, but really what you can see here was the greatest risk for C. diff was clindamycin, not surprisingly, and then the later generation cephalosporins. And if you look down here to the purple, what you'll see is really the lowest risk included minocycline and doxycycline. So again, sort of just reassuring in terms of C. diff risk with the use of DoxyPEP. All right, now in the last few minutes, we're going to talk about STI prevention, vaccines. So this study, kind of taking it back a little bit, was published in the Lancet in 2017. Again, a really clever design here where New Zealand had initiated a global campaign with the meningitis B vaccine. And so what they did, this campaign was initiated in 1984, 1985-ish. And so as that campaign was vaccinated, you can see kind of the left panel here is more and more proportion of the population being vaccinated. And then they waited till these infants had been vaccinated 20 some years later when they became sexually active and started acquiring STIs, and they looked at STI rates. And so a case was anyone with gonorrhea, a control was anyone with chlamydia. And what they found was that vaccinated folks were much less likely to be cases than controls, and showing this adjusted odds ratio of 0.69. So approximately 30% reduction in gonorrhea in this vaccinated population. And so kind of that paved the way for additional studies. This is the ANRS Prevenir sub-study. I could have mentioned it earlier on DoxyPrep, but it was a really interesting design, a factorial design, where they looked at DoxyPEP together with meningitis B. Folks who entered the study were randomized 2-to-1 DoxyPEP or no PEP and 1-to-1 meningitis B vaccine or no vaccine. And then, of course, the outcome was STI incidence. So this study also kind of confirms the use of DoxyPEP to prevent chlamydia or syphilis infection. It actually kind of surprisingly, I'm not showing it here, but there was a reduction in gonorrhea cases as well. What I want to show is that they initially at CROI last year thought that there was a reduction in gonorrhea with the meningitis vaccine compared to no vaccine. But notably, there was a press release in May of this year that the final analysis may modify interim results. And so we really need to stay tuned. We don't think that there's this reliable data that was presented, and we'll stay tuned for the final results regarding meningitis B vaccine. Notably, the MAGI study is looking at Bexsero, or the meningitis B vaccine. That is enrolling, I know, here and in several other sites around the US. And so that's a second study looking at efficacy of meningitis B vaccine to prevent Neisseria gonorrhea. And then I thought this was interesting too, that based on the results of the New Zealand study I showed you, as well as several other observational studies that have since been published, JCVI, which is the advisory group on vaccines in the United Kingdom, sort of the equivalent of our ACIP, is now suggesting that the use of this vaccine be considered to prevent gonorrhea. And so they're saying to consider this for gay and bisexual men who have sex with men who are at increased risk of becoming infected with gonorrhea. And then here you just see some criteria to consider. All right, and in the last minute or two, I want to wrap up by talking about DoxyPEP for the prevention of STIs amongst cisgender women. So some of you may be aware of this study. The results are, I think, unfortunate and sad for many of us in the field, but maybe leave some room for additional investigation in the future. But I think it's important to think about cisgender women bearing the highest burden of morbidity and mortality from bacterial STIs. I opened the talk thinking about congenital syphilis as a result of or in association with these really increasing rates of syphilis among cisgender women. And so as we may know, the sequelae of STIs in women are notable: PID, chronic pain, infertility, pregnancy complications, and HIV acquisition. And so here, kind of just cutting to the chase here, the time to incident STI was really no different for women in the DoxyPEP versus the standard of care arm. I will say that there was subsequent data presented at the HIV and STI World Congress in July looking at the adherence to doxycycline-PEP in this group. So despite the fact that reported adherence was very high, they did surveys and women reported taking it. There was a bit of a disconnect when they looked at a random subset of 50 participants. And if you can kind of look at this first bullet, 56% of participants had doxycycline detected at least once, which means 44% of this subset had no doxycycline detected at all throughout this study. So I think there's room for further investigation here. And I think we all remain a bit hopeful, or maybe very hopeful, that future studies show efficacy of DoxyPEP in cisgender women. I think I'm a bit running really close to time, so I'm just going to wrap up here, just showing the CDC does offer some guidance on doxycycline as PEP. We are waiting kind of official full guidelines. They did issue these for public comment in October of 2023. That time period to provide comment wrapped up in November. So we're waiting to see final recommendations from the CDC advising on the use of doxycycline as PEP. And then just close, if anybody has time to read this kind of review article by Grant et al. That was published in CID in 2019. It's a little dated now, of course, with these newer studies, but it really kind of just goes over some of the risks and benefits and kind of considerations in rolling out DoxyPEP and kind of what it means in terms of, things we need to consider for the microbiome, side effects, risk compensation, cost, and resistance implications. Okay, and with that, I will turn it over for the Q&A session.
Great, Meredith. Thanks for a great review. There are a couple of questions, but let me ask you a question that the last 40 STI experts I talked to couldn't answer. So I'm interested in what you think. And that is, for syphilis, gonorrhea, and chlamydia, we have great tests. We have cheap drugs. We know how to prevent it. Why haven't we been able to control this for the last 500 years?
Yeah, syphilis specifically, the rates just keep climbing. We did reach that nadir in 2000. We were all very excited that maybe we would I think some people use the E word, eradicate syphilis. And then unfortunately, since then, rates have just gone up and up. I think, I will say as I'm a huge PrEP advocate, and U equals U, staunch supporter, and talk to all my patients about it. But I think just over the last 2 decades, we have seen, with kind of this urge for, more sex positivity and decreased condom use, I think it just drives STI rates in the direction we don't want to see them go. And so now we have these potential prevention options, but implementation can be challenging, of course. But, I think people are always going to have sex. That's the bottom line. And people don't like condoms. That's the other bottom line.
All right, Clement, there's a related question from a lady, Candy, as to what's driving the increase in STIs. So I guess your answer is failure to use condoms and a lot of sex?
That sounds about right to me.
Yeah. All right. There's a comment from Ray Corin about a benzathine preparation that's available from Spain. Do you know anything about that, or want to make any comment as to whether that's going to impact availability in the United States?
So I have not, I've not been made aware that that's a potential option, and I haven't seen anything. I kind of monitor that NCSD website. I haven't seen anything about it there. It doesn't mean it's not coming. We do desperately need other manufacturers, right? Because like I showed this, we've dealt with this before, having only a single manufacturer, Pfizer, for bicillin, I think is a big problem.
Yeah, well, that's clearly a problem with so many different medications in this country. Could you just review quickly again the dose and timing of DoxyPEP?
Yeah, DoxyPEP.
Yeah.
So the way it was studied in the trial was 200 milligram dose, taken, within 24 to 72 hours, which I think confused people because they thought, well, should we be waiting more than 24 hours? Kind of what everybody is going with now is just take it as soon as possible after sex, up to 72 hours, but sooner is better. And really no more than 1 dose per day. So even if someone's having sex multiple times per day, just 1 dose per day.
And what do you think the uptake in clinics around the country is? Do you think people are adopting this, or is this still slow to become popular?
Yeah, so San Francisco, as the earliest adopter, has great data on tons of patients in their clinic who, thousands, I think, who are on DoxyPEP. So I really think it's very regional. In the kind of the West, Pacific Northwest, it's certainly happening more frequently. I'm in the South. I have colleagues I've talked to in the South. We're all doing it in some cases and offering it to patients, but I think it's a much slower uptake. I also actually think a lot of it might have to do with sort of the education level and savviness of the patients. So in San Francisco, where patients are reading all about this all the time, they come in asking for it. I really have had very few folks come in and ask. It's more me telling them about it. And so I think that's sort of a shame, and it's probably a lot is on us, right, to kind of raise awareness that this isn't a strategy. We do have PrEP clinics here who are and within our HIV clinic, we are offering it quite frequently now, but it's been a slower uptake.
Is there ever a chance of having a point of care syphilis test?
Yeah, so, well, there are 2 rapid tests right now, right? The syphilis health check and the dual combination test that's HIV and syphilis together. The limitations of those are that they're treponemal tests only. So they're really not helpful if someone has a history of syphilis, because if someone has a history, that test will likely, not always, but likely remain reactive for that person's lifetime. And so what needs to happen is a send-off RPR or titer. Yes, there are lots of diagnostics in the works, and they all have kind of some limitations, and I don't think they are going to be available anytime soon. But that's all our hope. That's really what we need, is a cheap, available, accurate, quick test so that we can diagnose and treat at the point of care.
Yeah, well, here's actually an interesting question about continuous antibiotics. Do you have any enthusiasm for continuous twice-a-day doxycycline for very high-risk people, especially those who get a lot of bacterial STIs?
Yeah, so this is what we're calling DoxyPrep. And it gets a little confusing with HIV prep and PEP and now STI prep and PEP. But that has been studied, very small studies in the past. And it actually, there are larger clinical trials ongoing about DoxyPrep. So I probably would be more inclined to do DoxyPEP right now, while awaiting kind of more reliable data on the use of DoxyPrep. But certainly, I think that's been entertained as a good possibility.
Yeah. And what about, are you actually advocating using 3 doses of benzathine for late latent, especially in people with HIV? Do you actually use up your benzathine for that?
Yeah, well, recently we've been using 28 days of Doxy kind of in the setting of the shortage and really preserving those doses for pregnant persons. There's really the data on latent syphilis is late latent syphilis is really terrible, right? And I don't know that we'll ever get better data because it's so hard to study. But what I'll say is that the kind of the idea is that or the theoretically, the treponemes are dividing more slowly in later stages of disease. So you do, or you should need a longer duration of treatment. So I do use 3 doses. I kind of want to flip that question for a second, because what I didn't talk about in my presentation was Jody Dion Odom's data that she presented at ID Week. So historically, in the setting of HIV, some people have used 3 weekly doses for early syphilis, right? And we now know definitively that that is not what we should be doing. The rates of serologic response for in early syphilis in 1 versus 3 weekly doses of BPG were exactly equivalent. So yeah, so 1 dose for early, 3 doses for late. I follow the guidelines for that.
And in terms of congenital syphilis, is there any geographic area which where most of the cases are they really spread across the United States for congenital syphilis?
Yeah, so I think that with the most recent CDC data, it was 29 states who had more than 100 cases. You know, we do tend to have poor kind of maternal and infant infection rates in the South in general, or outcomes in the South in general. And I know Texas has a number of cases. We have high rates here. But you know, I guess it's a little bit challenging because I know sort of absolute numbers more than you know, by population, but certainly California has a ton. Florida, you know, I think you could probably see a map on the CDC website specifically addressing that.
And the last question is from Kevin Carmichael. He said, "What would you do in your practice for cisgender women in DoxyPEP? Regardless of guidelines, what do you really do?"
Yeah, so well, first of all, we're trying to get a study started. But if I have women who really are eager to take it, I think it would be okay to counsel that, you know, we don't have great data to support the use of this. However, we don't have a good reason to think it wouldn't work in women, except for this study, but the study, again, had poor adherence rates, and just have a risk benefit. But really, I think on an individual basis, the risk to that individual in front of you is somebody who really wants DoxyPEP. I think it would be okay to do it. And I know in San Francisco, they are doing it.
All right, well, just to pin you down a little more, even if your patient didn't ask, if you had somebody with high risk, would you recommend it? As they say on TV, it's a yes or no answer.
I haven't been so far.
Yeah. Okay. Well, that's good enough. So,
But can I just real quick, just the data from Croy, kind of looking at vaginal secretions, and kind of the rates above the MIC, it should work, right? It should.
okay. Well, that's a good answer. So, okay. Well, Meredith, thanks very much for a very energetic and informative talk. So,
Okay, thanks for having me. I appreciate it.